Welcome everyone to our special session of HIV MRF HIV STI Echo. I am Dr. Boyce. There's a change in scenario today, not in the usual conference room as that's occupied, but we are still able to see you and reach you, and thank you for coming to share this learning exercise with us. So again, Dr. Chris Behrens is here to give his expertise and his insight on a topic we're actually starting to see more and more of post, the COVID pandemic. And as of yesterday, people stopped wearing masks in the healthcare settings and that sort of thing. But we do have some patients who are still having lingering symptoms, persons who have chronic kidney disease as a result of our COVID. And I remember at our last update, we weren't quite sure what a case definition was, who qualifies for long COVID, who doesn't. So I'm looking forward to find out from Dr. Behrens what advances have been made and how we can better assist persons who have this newly discovered, newly diagnosed issue with long COVID, and how we refer them appropriately and how we even identify cases of long COVID. So Dr. Behrens, thank you so much as usual, and I turn it over to you.
Okay, thanks very much. Always an honor and a privilege to be invited to speak to this group. So let me just get things situated properly. All right, so I'm going to talk about long COVID today with our usual acknowledgements of our sponsors. Sorry, just trying to get things out of the way here. Okay. And I have no conflicts of interest relevant here. By the end of this talk, hopefully you will be able to understand signs, symptoms, and well, what's currently known about the pathophysiology of long COVID, review some potential treatment options, and discuss strategies to prevent it. So what is long COVID? And Dr. Boyce, I'm sorry to disappoint you. I know you were hoping for a very, as you just mentioned, a clear definition of what this is. And sadly, a clear definition is still kind of lacking. And this is common when sort of a new disease appears. It takes a little while for everybody to agree on how to define it, and as well as what to call it. So this condition, you see various names for it. For the purposes of this talk, I'm calling it long COVID. This is kind of the term that's being used by the CDC here in the United States, but there are other terms for it, including post-COVID-9 condition, or PCC. That's a term favored by the WHO. United Kingdom uses ongoing symptomatic COVID-19 or post-COVID-19 syndrome. Other terms I have seen and that you may run across is the post-acute sequelae of COVID infection, or PASC. There's post-acute COVID-19, chronic COVID-19, post-COVID syndrome. We haven't settled on a firm term for this, nor have we settled on an exact definition. I think what these various definitions have in common is that we're talking about, sequelae of COVID infections that don't go away within a month or within 3 months, or within 4 to 12 months, again, depending on sort of which definition in that table we're going with. So just think of it as somebody who has COVID and just doesn't get better within the expected time frame and is left with some lingering chronic signs, symptoms, clinical complications. This is, I thought this was a useful graphic to kind of show what the sequence of events is. So we start, this is a time sequence on the x-axis. We start at the left side. Somebody acquires acute infection with the SARS-CoV-2 virus, and that can lead to either severe disease requiring ICU admission at the top, moderate disease in the middle, wherein patients are hospitalized but not in the ICU, or mild disease, wherein they are not hospitalized. And the thickness of the arrows in this graphic represents a rough approximation of, kind of what proportion of the individuals end up in those particular boxes. And so the vast majority of people, as we know, actually do end up with mild disease. They are not hospitalized. They're at the bottom. And of those, the vast majority go on to complete recovery. But a small proportion of even people who have had mild disease do go on to develop the post-acute sequelae of COVID-19, or PASC, as it is called in this particular graph. As you go up the ladder of severity, you see sort of a higher proportion of people progressing on to post-COVID, post-acute sequelae, or long COVID. So that's another aspect of this worth pointing out. Generally speaking, the sicker one is with the initial COVID infection, the more likely they are to progress to long COVID. However, long COVID is not exclusive to people who have had severe disease. Even if someone has had mild disease initially, they can go on to experience long COVID. And the long COVID, there's a considerable overlap with what's called the post-ICU intensive care syndrome, or PICS. And it's been known, long before COVID, that individuals who have to be admitted to the intensive care unit, they don't necessarily come out the same, even when they recover enough to leave the ICU and leave the hospital. They're often just more frail than before, and they have trouble recovering often to their previous level of function. So it can be challenging to sort of tease out in patients who have gone to the ICU for COVID, for example, how much of their ongoing clinical problems are due to quote unquote long COVID versus the PICS, post-intensive care syndrome, that we've sort of known about for quite a while. So that is, I think, kind of a helpful overview of where we're headed. Let's talk a little bit more about epidemiology of this. Again, the absence of a standardized, clear definition, of this, it really complicates estimates of the epidemiology. I mean, there is no blood test for long COVID. There isn't even a really clear set of criteria that is universally shared. I do think the best study that has been published to date regarding this question of epidemiology came out in JAMA last year. JAMA is one of the top tier journals here in the United States. And it was a meta-analysis of 54 studies and 2 medical record databases from 22 countries. So really a broad, far-reaching kind of a study. And it estimated that between March of 2020, so essentially right at the start of the epidemic, in January 2022, just over 6% of individuals who had had symptomatic COVID-19 were still having symptoms of long COVID 3 months later. Okay, so they're defining essentially long COVID at 3 months after that acute infection. And to qualify for this diagnosis of long COVID, not only did it need to be 3 months out from the initial infection, but also they had to have symptoms from at least one of 3 predetermined clusters of long COVID symptoms. And those clusters involved persistent fatigue with bodily pain or mood swings, cognitive problems, or ongoing respiratory problems. And so about 6% met those criteria. You can look at the relative percentages below. Of course, they add up to more than 60% because some patients experience symptoms from more than one of these clusters. So if I had to hang my hat on any one number, that might be the number I'd go with. Now, there are other studies that have found higher incidence. So, for example, this retrospective analysis from a big health record database in the US found that 20% of COVID-19 survivors between the ages of 18 to 64, and 1 in 4 of those 65 years of age and older had at least one persistent symptom or organ dysfunction that could be due to previous COVID-19. There was a study from Canada that showed that nearly 15% of adults at 3 months out were still having symptoms from SARS-CoV-2 infection or COVID, with it being more common among women than men. And then there was something from the Netherlands suggesting that about 13% of people with COVID-19 still had persistent symptoms 3 to 5 months later. So, I guess what this is suggesting, if you isolate the analysis to just some of these Western countries, maybe we're seeing higher levels of diagnosis. Maybe this is some sort of, ascertainment bias. As I mentioned, that the JAMA study was from 22 countries. Really, I think there's still a lot of lack of clarity. Perhaps 6.2% is on the low end. So what are we talking, though, when we talk about these symptoms? The most common physical symptoms are fatigue, shortness of breath, chest discomfort, cough, anosmia, or persistent smell, a loss. However, some of these go away relatively quickly, like the anosmia, for example. That usually does clear within a month, but some of these often last longer. So the ones above anosmia, those can often be persistent, and these are, I would say, among the most common physical symptoms. If we look at psychologic and neurocognitive, we also see high percentages of symptoms that persist in people with COVID. Impaired memory, poor concentration, or brain fog, very common complaint among these individuals, anxiety and depression. So I think broadly speaking, there's kind of this grouping of, the dominant pathology in long COVID being either neurocognitive or cardiopulmonary, or both, right? And so that's if we're sort of reading the tea leaves, that's the general pattern we're seeing. There are, of course, a lot of other physical symptoms that are being reported at levels less than 10% based on the studies that have looked at this. And they include a wide variety of issues: myalgias, insomnia, sweating, headache, dry mouth, joint pains, etc. So this is kind of an overview, again, of what we're seeing. But over half of these patients are reporting a reduction in the quality of life. And that also leads to questions in terms of what is the disability associated with this, because many patients are unable to return to full-time work, even as far out as 1 year after infection. So there was a longitudinal cohort study from a place none other than Wuhan, China, where it all started, involving over 1,000 people admitted to the hospital there, survived COVID-19, and roughly 1 in 10 of them who had been previously employed had not returned to work after 2 years. There was a study from Canada. More than 1 in 5 adults who survived reported persisting limitations to their daily activities. So I think the potential for disability from long COVID is not trivial. And I know here in the United States, many other countries, there are these persistent and real workforce shortage problems, and probably some of that is due to long COVID. So let's talk about what we know about the pathophysiology of long COVID. I think that the short answer is we don't know a whole lot yet. There's a lot of speculation, a lot of intriguing lines of evidence about what might be driving this. But much work remains to be done to figure out what exactly is going on. So again, this is meant to be kind of a timeline that shows the sequence of COVID infection, what happens during acute COVID-19, and how that feeds into the development of long COVID in some individuals, along with some factors that are a little bit potentially protective or additive to the risk of developing long COVID. So, for example, we know that having underlying comorbidities like diabetes, obesity, asthma, can actually increase the risk of developing long COVID. We also have seen that as I will show, actually, vaccination is a bit protective. Female gender in some studies may be protective or might actually not be protective. So it's kind of literally a gray bar in this picture. But some of the theories that are being investigated as to what's driving long COVID include autoimmunity and immune dysregulation. Interestingly, some of this is involving investigation to deranged T cell activation and B cell dysregulation. And, we're starting to see some biophathophysiologic theories that kind of align with the way HIV behaves. Ongoing inflammation is a very hot topic of research and is very likely present in people with long COVID. That's been documented with elevated levels of various markers of chronic inflammation. There has been some evidence that the virus is persisting, can still be found, or at least fragments of the part of the virus can be found in many patients who have long COVID. Persistent tissue damage from the acute COVID illness, as well as secondary infections, in some patients are causing sort of a more or less permanent damage to the affected organ from which they cannot recover and are driving the ongoing symptoms. There's interest in whether the infection is somehow disrupting the microbiome in the gut. And then there's investigation in metabolic dysregulation and potentially imbalance in the renin-angiotensin system. So, it's all too vague, I think, at this point to warrant a deep dive into each and every one of these. It would take far more than the time we have, and furthermore, it's all too preliminary. So I'm just going to put out that these are some of the theories that are out there and are being actively pursued. But I would say, broadly speaking, we just don't know exactly what's driving it at this point. We can talk a bit, though, about the clinical manifestations and the implications of it. So the interesting thing and sort of tragic thing about long COVID is just how many organ symptoms seem to be at play here. And people who survive COVID, for a respiratory infection, it seems to cause problems throughout the entire body and all these different organ symptoms. And I mentioned that, the most common complications seem to fall on the axes of neurocognitive and neuropsychiatric complications, as well as sort of cardiopulmonary complications. But there are others. There can be complications in terms of kidney injury, endothelial dysfunction could be driving a lot of the problems we're seeing throughout the body. A lot of persistent GI problems. Maybe that's related to disruption of the microbiome in the gut. Maybe it's related to endothelial dysfunction. And then a lot of musculoskeletal sequelae as well, and some evidence of immunological dysfunction. There's been speculation that following COVID in the wake of COVID, we're seeing increased rates of other infections, like sort of unusual outbreaks of group A strep infection, for example. So there may be some sort of persistent damage to the immune system that's going on as well. This is a kind of a table that tries to sort out all the various symptoms, really, that patients might present with, signs and symptoms that your patients might bring to a clinical visit, what signs you might see at the exam, again, along these different organ system axes. And if seen, what you can do about them in terms of, further studies to consider and possible referrals. I would say that, the studies to consider in addition and the referrals to consider based on that, there's not a whole lot new here, right? This, I think, in someone who didn't have COVID, these are the kind of things you would think of, the tests you might consider ordering and the referrals you might consider making. So again, in the absence of a better understanding of what's driving it, I think we're kind of reverting to symptomatic management and trying to exclude the presence of other underlying problems, the way we did for people, before COVID. But nevertheless, there may be some utility, hopefully, in sort of knowing that approaching people with long COVID symptoms, at least at this point, does not involve somehow completely reinventing the wheel or taking us on a completely different direction. At least for now, honestly, I think we're looking at the presenting signs and symptoms, trying to look for underlying causes and treating as best we can. Now, as I mentioned, neuropsychological, cardiopulmonary seem to be the most common complaint sort of complexes we're seeing. So based on that, let's dive a little bit deeper into those two kinds of issues. In terms of neuropsychiatric sequelae, well, these are some of the ones that are being most commonly reported. Brain fog is a really common one, which it sounds like a very sort of non-specific term, but it is used frequently because people with this, they just feel like their brain isn't quite working right. Memory doesn't work as well. They can't concentrate as well. They have difficulty finding words. And, we can think of related diagnoses, and we can think of possible mechanisms for these. But I think it's useful to know that if someone is presenting with these kinds of complaints and they have had COVID, well, they're not alone. And that this very well could be part of the long COVID syndrome. Knowing that, even if we don't know exactly what's driving it or how to treat it, just knowing that can be very helpful to patients, to know that, this, to clear up a little bit of the mystery for them and say, yeah, these symptoms are real. You're not alone. We are seeing these kinds of symptoms in other people, such as yourself, who had COVID, particularly a bad case of COVID. And there's ongoing research to try and figure out, what we might do about it. And so just to complete the list, a lot of mental health disorders, either aggravation of pre-existing psychiatric problems or the new occurrence of mental health problems, that's also being seen very commonly, especially depression and anxiety, but sometimes these are pretty severe, hallucinations, delusions, paranoia, catatonia. These are being seen as well. So again, I think it's good to know the spectrum of neuropsychological, neuropsychiatric, and cognitive complaints that we're seeing in people with long COVID, and be able to counsel our patients accordingly that, well, this could be long COVID. All right, so this is kind of an interesting diagram that's been proposed for, you know, how these problems might be occurring in the first place, and to think about possible treatments for them. So we start at the top really with acute COVID-19, and we know that there's, you know, multiple bad things that happen during acute COVID infection illness. Direct infection of various neurologic cells, massive cytokine release, and then there's the associated immune response. And we know that in the setting of acute COVID, there is a potentially therapeutic role for antivirals, such as what we call Paxlovid, and also immunomodulators can also help a bit. In some cases, you know, steroids are indicated, etc. But once we get into long COVID, you know, you see the shading of those green boxes is lighter, meaning that these are all, you know, unknown, experimental, and a lot of question marks. In fact, virtually every box has question marks. So, so these are areas of investigation, but a lot of sort of unknown. We really don't know at this point exactly what to do to treat these neuropsychiatric complications of long COVID, apart from, well, treating them the way we would treat anyone who hadn't had COVID, right? As best we can until we get more information. In terms of cardiovascular complications, these are various studies that have shown really a significant proportion of patients experiencing at least any cardiovascular event. At 9 months out, 14% of patients who were admitted to the ICU had some kind of long-term, you know, cardiovascular event that occurred long after the initial COVID infection. There was another study in the United Kingdom that found 30% rates of rehospitalization and high rates of major adverse cardiac events. Now, these are in patients who were so sick they're in the ICU, but still, these are sort of kind of frighteningly high, you know, levels of cardiac pathology in people who were in the ICU with COVID, you know, on follow-up. You know, more subtle findings, not you know, not quite as common, but I think those top two ones are the, you know, the top two lines in this table are the ones that sort of jump out at me, that, you know, patients who are hospitalized in the ICU with COVID, they are at high risk for cardiovascular complications down the line. And so we do need to very much focus on their cardiovascular health in the aftermath of a severe COVID illness. And here's a study that that I believe came from the VA system, looking at the 12 months out disease burden, again, ICU treated COVID patients, and they went back and they compared them to control patients, patients, you know, who had been in the ICU but not because of COVID, right? And so the investigators asked, well, hazard ratio at 12 months of these patients having certain cardiovascular complications, and the hazard ratios are quite high, right? So it wasn't just being in the ICU, because the control patients also had been in the ICU. The difference here is these patients were in the ICU with COVID, and their risk of a broad array of cardiac complications 12 months out, see dramatically elevated risk in these individuals. So again, we need to be very attentive to the protecting the hearts of people who have had COVID and have been in the ICU, because they're clearly at significantly higher risk of developing various complications. Now, I mentioned pulmonary complications are also one of the more common long-term sequelae of COVID. And I think you can think of this as, well, the presenting problem that your patients will come to is, feeling short of breath, right? And that could be due to, disease specific to the lungs, or it could be due to problems outside of the lungs. For example, it could be due to heart failure, or it could be due to sort of frailty, other things that cause reduced exercise tolerance. So just to kind of think along the lines of separating out, when your patient following COVID is complaining of shortness of breath, that can be due to pulmonary direct hits to the lung, or it can be due to the impact of other problems outside of the lung that all contribute to this sense of feeling short of breath. So we have to take into account the possibility of post-intensive care syndrome, again, in individuals who are admitted to the ICU. I think for many of these patients, it's very helpful to perform pulmonary function testing and imaging to try and distinguish, well, is this a problem confined to the lungs? How bad is the lung? Is there something in the PFTs or imaging of the lungs that we can find and treat? And then, of course, there's all the physical deconditioning and frailty that occurs in the setting of an acute illness, especially in people who are in the intensive care unit. So there are various rehabilitation and care approaches that really vary according to, what we determine to be the main contributors to their shortness of breath. Okay, so let's move on to talk about treatment of long COVID. As I've sort of alluded to, we don't really know. So at the moment, we're mostly, trying to treat the illnesses with which our long COVID patients present. We're looking at their signs and symptoms and, ruling out other things that may be contributing and managing those symptoms as best we can. There was a study being performed out of Stanford University that was looking at treating long COVID with Paxlovid, the same medication we use to treat acute COVID. And if, as some of the studies suggest, there is persistent viral replication of SARS-CoV-2 in patients who have long COVID, well, then it might make sense to simply try and stop that replication and see if people get better. Unfortunately, this trial was stopped early. They were, gearing up to enroll 200 participants who would receive either placebo plus ritonavir or the Paxlovid for about a 2-week course. There was an interim analysis that occurred in June, and based on that interim analysis, it was stopped. Now, they haven't provided any further details. Typically, when a trial is stopped early after an interim analysis, it's almost always because it either showed no benefit or it showed such convincing benefit that it would be unethical to continue. If the trial had shown such convincing benefit that they were unethical to continue, well, then the next step would have been to open up trial participants to all receive the Paxlovid. That didn't happen. So I think the reasonable assumption here is that at an interim analysis, they were seeing absolutely no benefit. So it was considered futile to continue. Hopefully we will get a little bit more clarity sometime in the near future about just what would happen and with that. But so far, it looks like this was a negative result of a 2-week course of Paxlovid for long COVID. However, just last week, or earlier this week, the NIH announced some trials that they are opening up and sponsoring for various treatments of long COVID. It's broadly speaking, this is the Recover Initiative, a $1.5 billion effort that was part of a large bill passed in the United States 2 years ago. So fortunately, we are at least going to see more trials coming down the pipeline. Obviously, it'll take some time to see any results from these studies, but we're looking at probably at least a few different trials involving various treatments. So far, we've got like 5 different kinds of treatments being looked at in the context of these various studies. So we'll just have to be patient and await results from these. So given that we don't know a whole lot about how to prevent or how to treat long COVID, but we do know that the epidemiology and the disability are real, what can we do to stop it? Well, I would say there are sort of 3 avenues that have shown promise for prevention of long COVID. One is immunization, second, Paxlovid, and the third, somewhat surprisingly, but very hopefully, is metformin. So let's walk through these. Getting vaccinated against COVID, well, it not only it prevents or helps to prevent the initial infection with SARS-CoV-2, it helps to reduce the severity of infection, but it increasingly looks like it also reduces your risk of getting long COVID if you end up getting COVID anyway. Various studies have looked at this, and there seems to be probably a sort of a dose-response relationship here. So, for example, of the 5 studies that looked at the impact of getting one vaccination prior to contracting COVID, 4 of those showed no benefit. One of them did show benefit, but I suspect if you did a meta-analysis of those 4 studies, it just looks like one vaccination probably isn't doing much. 2 doses, however, 2 vaccine administrations prior to getting COVID does appear to be protective. At least the majority of the studies that have been performed in that context do show a protective benefit. Only 1 study looking at 3 doses before infection looks protective, but kind of a wide confidence interval there as well. Now, if we look at like having received any dose before infection, 1, 2, or 3, well, according to there were some studies that really didn't tease out how many. Again, you see a mix. On balance, I think there is this probability that yes, having received 1 or more vaccines probably protective. There were a couple of studies that were interestingly looking at what about getting vaccinated sort of after the fact. What about getting a vaccine after you've had COVID, or even after you've been diagnosed with long COVID? Some of those studies, most of them, in fact, seem to be showing that there may be benefit there. And those were looking at just 1 dose. There are only 3 studies looking at 2 doses after infection or after the diagnosis of long COVID. I would say not, on balance, those 3 studies are not showing a benefit, but broader confidence margins. So, there's all kinds of good reasons to get this vaccinated and remain fully vaccinated against COVID. I think the data we have support the idea that vaccination does confer some protection against long COVID as well, especially if you've received at least 2 doses of vaccine prior to getting COVID infected, and that there may be benefit for continuing to get vaccinated even after one has had COVID, or possibly even in the setting of long COVID. So another good reason to get vaccinated, to stay up to date, and a messaging that can be conveyed to our patients who may have ongoing vaccine hesitancy. This was a study looking at Paxlovid, and what does Paxlovid do in terms of reducing the risk of developing long COVID? So this is a Veterans Affairs, or VA, system study here in the United States. And the VA, is useful for these kinds of studies because it has this enormous database. And they had they had nearly 300,000 patients in this cohort review, who all of whom had COVID, right? And about almost 36,000 of them received Paxlovid within 5 days of their diagnosis. The control group of about 250,000 patients also had COVID, but they didn't get that treatment. And then they looked at, what were the rates of long COVID between these two groups? And what they found was that receiving Paxlovid, or nirmatrelvir, was definitely associated with a reduced risk of, what they called in this study, post-COVID-19 condition, or PCC. Again, this is just another one of those terms that is used to denote long COVID. So that's the risk ratio was 0.74. So it, broadly speaking, it seemed to reduce the risk of developing long COVID by about 25%. And this was very highly statistically significant. Also reduced the risk of death in the, following that acute illness. It reduced the risk of subsequent death by about half, as well as hospitalization. And this reduction in the risk of long COVID occurred in people who were vaccinated, and those who were not vaccinated, and people with their first bout of COVID, people with reinfection with COVID. So it kind of seemed to very much help in terms of reducing the risk of long COVID and of death, regardless of the context. These are just some of the graphics that sort of show this numerically. The PCC, or long COVID, relative risk reduction, about 0.74 there. Now, it is important. I mean, that relative risk that we're seeing here in these hazard ratios, definitely statistically significant, and it's a significant magnitude. It is relevant, of course, to always look at what is the absolute risk reduction, and that's a bit more modest because, of course, most people don't go on to develop long COVID, or don't go on to die or be hospitalized in the aftermath of the acute COVID infection. So this is why I've included on the right the absolute risk reduction as well as the relative risk reduction, because the absolute risk reduction is real, but it's not quite as dramatic as a relative risk reduction here. Okay, they sort of analyzed the data to show exactly which aspects of long COVID were being, prevented, or at least risk reduced by the use of Paxlovid in these patients. And the ones that are significant are shaded in blue, and the ones that were statistically not significant are shaded in orange. So just included that to look. There didn't seem to be much of an impact on, for example, diabetes, liver disease, or a cough, but but across virtually all the other domains, there was a statistically significant reduction. These are the Kaplan-Meier graphs just showing exactly how did that benefit play out over time, and both in terms of developing long COVID and in terms of preventing death. And as you can see, the impact of Paxlovid seems to kick in early and is sustained, over the course of about 6 months of follow-up. So I think that's, significant. They also looked at, various subgroup analyses to see, well, is this only applied to men, women? Is there ethnic disparities? And, what about pre-existing conditions, for example, smoking, et cetera? Essentially, it seemed to work regardless of any of those, among all these risk groups and profiles, no matter how you slice the data, it seemed to help everyone. And then they also looked at, again, whether individuals had been vaccinated or not, and how many vaccines they had received, whether this was their first COVID infection or subsequent, how many risk factors they had. Again, it was useful across the board, sort of regardless of these different parameters and variables. So I think this is, persuasive evidence that Paxlovid, if given within 5 days of acute COVID infection, does reduce the risk of developing long COVID. And I think that really should figure into our clinical decision-making around, providing Paxlovid to people who have it. For me, it's, to me, this feels like a no-brainer. Any adult who has COVID, I'm going to offer them Paxlovid if there are no contraindications, even if they don't have any risk factors, because long COVID can be such a devastating complication, and Paxlovid, it really is a safe medication. You have to beware of certain drug interactions, but apart from that, it is a safe medication. And if it has the potential to, prevent a few cases of long COVID, then I think it's worth prescribing it. For the sake of time, I'm not going to go through this table, but I thought it might be useful for you to have this, and you'll have access to these slides afterwards as to what were the exact hazard ratios for various complications seen in long COVID, and what were the absolute risk reductions as well. Okay, and then last but not least, there's been this intriguing finding about the role of metformin in preventing long COVID. So this came from the COVID Out study, which the COVID Out study was actually a double-blind, randomized, placebo-controlled trial to test the effectiveness of 3 different medications to treat acute COVID infection, right? And they took metformin, they took ivermectin, they took fluvoxamine, and none of them worked, okay? None of these medications work in terms of doing anything significant in the context of treating acute COVID, right? It didn't change the fate of those individuals. But interestingly, the investigators continued to follow these folks, or at least many of them, for longer periods of time. So out of the 1,300 trial participants who were originally in this COVID Out study, about over 1,100 consented for long-term follow-up, and the vast majority of them completed over 9 months of follow-up. And so of those, about 8% reported having been diagnosed with long COVID. This kind of fits with the, roughly 6% we saw in the study earlier. And what they found was that if the patients they've been following had received metformin as initially as part of that randomized arm within the COVID out study, they were much less likely to actually develop long COVID. The hazard ratio for metformin recipients in terms of preventing long COVID was about 0.58. It was about a 40% reduction in the risk of developing long COVID. It was even more significant when the metformin was started within 4 days of symptom onset. So I think the bottom line is right there down at the bottom in red. A 42% relative decrease and a 4.3% absolute decrease in the long COVID incidence occurred in participants who received early outpatient COVID-19 with metformin compared to placebo. This was unexpected, but a very pleasant surprise, right? Because metformin is inexpensive. It's pretty safe. We're very familiar with metformin and its potential side effects. It's such a commonly prescribed medication. To me, granted, it's one study, and it's sort of a tag along to initial study, but nevertheless, given how few drawbacks there are to prescribing metformin, personally, I'm persuaded that if I have someone who has acute COVID illness, I'm gonna, prescribe them metformin in addition to the Paxlovid. Again, if there are no contraindications, because these are convincing data that it may significantly reduce the risk of developing long COVID. This is the Kaplan-Meier graph that's relevant to the study, showing the difference over time between the metformin and placebo groups in terms of reducing the risk of long COVID. Again, you see that difference occur relatively short and is clearly sustained over time. These are just the numbers that I want you to have for reference as they accumulate over time as well, along with the absolute risk reduction over time. And then breaking it down by subgroup analysis, where there's some that seem to benefit more than others. Broadly speaking, it was more clearly effective for women than for men. But there's a broad confidence interval for the men. The point estimate is protected, but it crosses one. So the numbers weren't, I think, in some ways big enough to be totally sure about some of these. But at least we can say that there was clear evidence of if you look at women, if you look at individuals with high body mass index, those who received it in less than 4 days of treatment onset, those less than 45 years of age. So we see again sort of a wide spectrum of activity across the subgroups. I think the helpfulness of breaking it down by subgroups is, however, significantly compromised by the fact that the sample size, the number of participants just wasn't big enough to be able to avoid these very wide confidence intervals. So just to summarize with some key points here, post-COVID-19 condition or long COVID, PASC, heterogeneous clinical syndrome affecting multiple organ systems, pulmonary and extrapulmonary disruption are common, of which the pulmonary sequelae include various thromboembolic disease, microvascular thrombi. There can be alveolar injury from the illness itself that can lead to fibrotic lung disease, for example. People with pre-existing respiratory conditions are at higher risk of having more ongoing symptoms of those after COVID-19. But if they only have mild to moderate asthma and COPD, they don't have increased risk of severe COVID illness in the acute phase. Current rehabilitation strategies to manage these individuals who commonly present with shortness of breath overlap quite a bit with what we've been doing for patients who come out of the ICU. And at this point, we don't have a whole lot to offer beyond what we've been offering those patients all along. We certainly know about the role of vaccines, antivirals, anti-inflammatory medications to reduce morbidity and mortality in the setting of acute COVID. In the setting of long COVID, we just don't really know how best to treat those. We hope to acquire some more information soon. We've only seen one presumably negative clinical trial of Paxlovid to treat long COVID. If, however, we can recognize and treat acute COVID early on with Paxlovid and or metformin, there is significant evidence that reduces the risk of developing long COVID, as does vaccination. Vaccination definitely seems to appear to reduce that risk of long COVID as well. But bottom line, we need a lot more information, and hopefully that will be forthcoming, especially from these clinical trials that were just announced by the NIH. And that's just the United States. So we're going to see a lot of studies pouring in from other countries as well. So I'll stop there and open it up to questions and discussion.
Okay, thank you, Dr. Behrens. As usual, a comprehensive overview. We may have time for just one question if someone gets in quickly. Don't want to rush anybody, but we might have just time for one question.
Yeah, no, I'm not under any time pressure, so I can go a little bit late too.
All right, great. So again, you can raise your hand or just unmute and start asking if you'd like. I'm not seeing anyone talking just yet, so I'll sneak in one of mine. I believe one of the conversations that was ongoing is the potential for, long COVID to be the sting in the tail for the pandemic because of the potential economic impact on healthcare systems and strain of healthcare systems in the long term with persons who have now chronic lung disease, chronic kidney disease, frailty, as you said, people not returning to work. What is your sense on what that might look like? I mean, as I said, there's not a lot of data now, but given your experience, what do you think that might grow out to be in the future?
So just clarify, are you talking about what the impact on like healthcare workers of long COVID and therefore not being able to work, or the impact of the increased disability and medical problems in the population at large, and what impact that might have on access to the healthcare system and overwhelming the healthcare system?
Yes, sort of the latter part of it, so that in the sense that in the hot part of the pandemic, we were worried about overwhelming the healthcare system and overburdening the healthcare system. Is long COVID now going to be the slow burn of that is going to put require additional resources in the healthcare system, but not acutely, but over a longer time?
Well, good question, and certainly it's being talked about. I think there is that potential for if there's a big wave of long COVID coming down the pipeline, as many people are speculating, well, that's yet more chronic illness and that needs to be somehow addressed by healthcare systems that are often really struggling just to keep up with the current situation. I think it's very hard to predict because there's still, we're starting to get some clarity on the, sort of the prevalence of, or incidence of long COVID, I should say. There's roughly 6.2% from that very large study, maybe a little bit higher from other studies, but wouldn't be surprised if ultimately it settles out in that 6 to 9% range, let's say. But then what remains also unclear is how many of those patients who are diagnosed with long COVID recover ultimately, because I have seen documentation that, well, often these patients do get better, right? However, as has been pointed out, the studies that suggest that patients with long COVID are recuperating and getting better, they're basing that on the fact that patients that have been diagnosed with long COVID are no longer coming back to clinic for follow-up visits. And so they're sort of assuming, well, it's because they're doing better. Well, it could also be because they've given up, right? They have long COVID, they obviously symptoms, we don't know how to treat them. We have virtually nothing to offer them, and the patients reasonably stop even bothering to come to clinic, especially when they're feeling so fatigued and crummy. So when you're trying to estimate, what kind of burden this is going to be on the healthcare system, you need to know not just the incidence of long COVID, but you also need to know how long will long COVID last? And that to me is really, really unclear, right? If it's going to be permanent, well, that's, for the vast majority of these patients, then that is a very high level of disability we're facing. But if on the other hand, you know what I mean, long COVID is just granted a very unpleasant and prolonged course, but if people get better on their own and long COVID is limited to 6 months or so for the vast majority of people, then it's not going to be nearly as big a burden. So that's my long way of saying I have no idea.
So I'm seeing a question and a message in the chat. So question from Rickson Thomas, in terms of definition of vaccination for COVID, how is that defined? For example, 2 weeks after receiving the original mRNA injections, or does that include the booster? Do you know how they define it in the study?
Right. Well, it depended on the studies. The studies kind of teased it out when they were looking at the protective impact of the vaccines. And let me see if I can just pull that up again and see if I can find. So here I think this might be the relevant graph that hopefully you can see of the relative benefit of how many vaccine doses received before getting COVID, right? With 1 dose, 5 studies done looking at that scenario, 4 of them showed no benefit. But 2 doses before infection, there were 8 studies, and it looks to me like all but 2 of those 8 studies did show a benefit. So my take is that having received 2 doses of COVID vaccination provides some protection against long COVID.
And a comment from iPhone. Thank you, Dr. Behrens. Here in the UK, we are hoping that the Simulate ICP trial currently being run at the UCLH will yield some positive results. We are seeing clients in the community, long COVID service, who have had long COVID symptoms for over 3 years. Many have not been able to return to work. Let's see, I think that's a question from Cyrus. I think they've been covered in terms of the immunity vaccination question. And from Margarita Elliott, my concerns are for PLs, the clinical treatment you touched on the clinical treatment touched on the very hopeful metformin as a very promising option, but there is a powerful physiological component to treatment which may be needed. I'm not sure that's supposed to be psychological. The mental health piece as well. Thanks for a very good session. Okay.
Yeah, the mental health complications from COVID are alarming and kind of surprising. I don't think we've seen. I mean, I'm struggling to recall a similar situation where we see such a common complication of a respiratory infection causing mental health problems, right? It's really kind of bizarre. And it's not, I mean, there are analogies. We know HIV disease can cause HIV-associated dementia, for example. But we don't see HIV disease necessarily, triggering, well, apart from adjustment reactions and sort of the situational anxiety and depression. It's just kind of remarkable, and it just underscores the whole mind-body connection that I think has perhaps been underappreciated in the past.
Yes, thanks for that, Dr. Behrens. So I'm not seeing any new questions in the chat or no hands raised. So I just want to do a quick shopkeeping. So our next session will be in 2 weeks, entitled "An Update in Cryptococcal Disease in Persons Living with HIV." Dr. Behrens will join us again to give us some updates, because there are some very interesting updates coming in. And it's especially relevant in the context that we are currently going through histoplasmosis cryptococcus TB study in concert with PAHO and CDC and the Ministry of Health, trying to get a better handle on the burden of fungal disease among persons living with HIV and AIDS in Trinidad and Tobago. So that's perfect timing, Dr. Behrens, as usual. And I just want to thank everyone for coming on a rainy Friday afternoon to join us. Take care from me, Dr. Gregory Boyce from MRFTT HIV STI ECHO. And we shall see you back in 2 weeks. And again, a big thank you to Dr. Behrens.
Thanks.
All right. Take care, everyone.
So, Greg,
yeah.
Before you sign off, give me a couple of minutes when everyone has left the room.
Sure. Is Bernie still here? Oh, yeah, she is. There we go. Hi, Bernie. Good to see you. It's been a while.
I'm trying to. Where is?
You're still host, right?
No, that's what it is. I'm not host.
Oh, you're not host.
Now.
Okay, so
That's what I was able to put anyone in.
All righty.
So I was trying to find out who that person in the UK was, but I wasn't able to find out who that was.
I actually, no, they said in the UK they did, so I have no clue who that is. No clue whatsoever.
Because we have someone. Are you maybe co-host again?
Did I?
No, you haven't.
Yeah.
Bernie, we're gonna put you in the waiting room. There we go. Right.
Yeah.
Yeah. So I was trying to find out who that person was, but they weren't answering. Because they was like here in the UK. I was like, who is that?
Yeah, okay.
Because we have a US person that attends, but I never had anyone really attend from the UK. So I will make a note of that. But the next thing is I was speaking to Dr. Behrens. We're supposed to do 2 sessions with him in September on the 8th and the 22nd. So we may not be able to do the one on the 22nd.
Yeah.
Because that's the week that we have Chris here.
Yeah.
But what he said is he just did one that was ethics and HIV.
Ethics. Okay.
And he had some interesting case studies that he kind of looked at for it. Because the other option was syphilis, diagnostic and mentoring. And I think we've done stuff on syphilis through Dr. Edwards.
Yeah, yeah.
So I will just tell him yes for that ethics
Mhm.
case study, and I'll tell him we'll do it on the 8th. And unless he's available on the 15th, that will be the last echo for this rock season.
Okay, cool. No problem.
Awesome sauce.
Lovely. All right.
You're going one time?
Let me just pop my head out because I think CDC might still be here to see if they need any assistance.
If not, we can chat later.
Okay, no problem.
Yeah. All right. Okay.
Take care.
Bye-bye.
Ciao, ciao. Bye.
Too many screens I can't find. There we go.